This conference will now be recorded.
Okay, hello everyone. Thanks for joining us today. I wanted to first of all tell you that we have been working pretty hard with Erica and her team to try to, kind of come up with some good answers for you for visitation. Not only in, I put nursing home on this, but it's also for the other facility types as well, acute care hospitals as well. So we'll address these questions as we go. We're going to
I'm
go
gonna mute everybody really quick because we're getting some feedback, and then unmute yourself, okay?
Okay.
Okay, unmute yourself.
Okay, so I'm back. All right. So the agenda for today, we're going to talk about the survey status of where we're at as a certification bureau. We're going to talk about the QSO 2039 revisions that were sent out, I guess, here in March. And then we'll talk about the critical access side of things, the questions that were submitted. There is one IP, I think, or maybe a couple that were there, submitted questions that Erica addressed specifically, and then some long-term care submitted questions. And then if we have time, we'll certainly address any other questions you have the best we can. So as far as our survey process and where we're at, we have started our recertification process for long-term care and for hospice and home health agencies in the state. This is primarily because the focused infection control surveys have gone down, or requests from CMS for us to do those, I should say. As you may call or may or may not know, they were sending us a list weekly, which they still are, indicating where we needed to go for these focused infection control surveys for long-term care. So they are, I think, the past at least 4 or 5 weeks, we haven't had any to do, so which is good, and is kudos for you out there working and controlling, the COVID issues in your facility. So thank you for that. So these are the areas we're working on right now, and will for the next couple months anyways. Including complaints, focused infection control surveys if they're required. Hopefully we're not going to see those right now. And then we'll jump into what we call tier 2 as time allows. And tier 2 can, and I failed to list the mission and priority document. It's an administrative document that CMS issues to us. And I'll add it before we send this out to everyone. But anyhow, it's a document that they issue every year and tell us these are our priorities. And it goes from tier 1 through tier 4 for each provider type. And some of them have multiple, some only have one tier that we have to comply with as far as the survey process. So anyhow, I'll include that link here for you in the revised edition of this. So those are where we're at, and we are, like I said, we are out doing recertification surveys for long-term care. A question may be for long-term care, for example, is, well, it's been over, the 15.9 months, which is the maximum since you've been in. It may be 20, it may be even 22 months. We're trying to get them back on the schedule as quickly as we can and do them. I'll be honest with you, we're trying to also consider travel areas and things like that as far as winter travel versus not, to try to get an idea of when we can do those in summer months, to try to balance out our schedule a little better since we're given this opportunity. So there's nothing you need to do at this point as far as recertification. CMS is not dropping anybody, including for hospice or home health or anything at this point. It's really on us to do the survey and complete those. So anyhow, those are the survey or the status for us as a survey agency. next, going on to this revised QSO memo that was issued on the 10th of March. And it was really to add more guidance to the nursing home visitation requirements. And specifically now that the vaccinations have been issued or been going on throughout facilities and throughout public in general. So they added a lot of information about that, what it means. They do bring up some information that's probably of interest to all of you about close contact with someone with COVID-19 in the prior 14 days, regardless of vaccination. So that's a big issue, trying to determine, if a person goes out or a resident goes out and is in the public and they may be vaccinated, but as they come back, were they exposed to somebody that had COVID or was diagnosed with COVID? So that's one of the challenges that have come in. Although vaccination is good, there is some, things that CMS wants us to make sure that is occurring as far as screening and making sure as your residents come back that you're, confident of where they're at as far as their infection status with COVID. So that's one thing they kind of pointed out in there. The others are outdoor visitation. They did some modifications to that. It does lower the risk with vaccination. And really, this is where they recommend, at least, when you read this, it talks about outdoor visitations being a lower risk for even with the vaccination for exposure to COVID-19. So they talk about that. They also talk about now what fully vaccinated is, and they give a definition of there. And I believe really what it comes down to is they're fully vaccinated after 2 weeks following the receipt of their second dose, or if it's a one-time dose for some of the vaccinations, then 14 days on or 14 days after that, they're considered fully vaccinated. So just something to clarify with you as well. And then indoor visitation, they started addressing, it should be allowed regardless of vaccination status. They talked about limiting of indoor visitation, if you have unvaccinated residents and a counted positivity rate. And so they dealt with that in a dual manner, and we'll address this as we go through this as well in detail.
Yeah, but how do I just say got it?
You got it.
Got the microphone going on.
I'll take care of that for you, Todd.
Okay, thank you. So the county, again, that county positivity rate, we'll go into this a little more detail throughout this presentation. And the vaccination of residents. So
those are initials.
just a reminder to mute yourself if you would, please. Thank you. Residents with confirmed COVID-19, regardless of the vaccination status, until they meet criteria to discontinue transmission-based precautions. So things that you're going to have to consider about indoor visitation. Residents in quarantine, regardless of vaccination status, until they meet requirements for release from quarantine. So again, they're trying to get you to follow those. The one thing that after speaking with CMS or having them present to us about this whole limiting of indoor visitation and dealing with COVID positivity that comes in later, or you're starting to see an outbreak again, they do point out that you want to deal with it on a case-by-case basis, and you want to deal with your local and your state officials as far as what our restrictions should be in place, what shouldn't, to help you manage that. So use the epidemiology folks like Erica and her group. You can ask us questions as well. We're waiting for CMS to give us survey requests to go out to do these focused infection control surveys. So just because you have an outbreak doesn't mean we come out. There are outbreaks we know that are going on, but They're just been controlled and limited. So we don't just show up. So the last thing I think on this slide that talks about is mention adherence to core principles of the COVID-19, and specifically the physical distancing and hand hygiene, and it goes on. There's again, if you refer to 20-39 NH, it brings it up right in on page 2 that talks about, you know, use of face coverings and cleaning and disinfecting of high touched areas in the facility, approved use of the PPE in the facility, effective cohorting of residents. So those are the core things you want to. The other thing is signage too, to make sure that's occurring, that signs are posted and people are aware. And then there's also some testing that you need to be doing too as well with outbreaks and things. So those are the things that I think are important for you to consider. These are the revisions. And continuing on with the revisions, there are some others for indoor visitation during an outbreak. So then it breaks it down, and they've added a pretty good section here. CMS have that includes.
I'm really sorry, but can you reshare your screen? Somebody else somehow became a presenter and started sharing theirs.
Oh, sure. Sorry.
Thank you.
You bet. How's that?
Now we see them. Perfect. Thank you.
Okay, you're welcome. So the second part of this is indoor visitation during an outbreak. And again, they added a whole section here specifically for this because they realized that, you know, you may have another positive case come up here or there. Again, it only takes one resident or one staff member to have a positive test, and then you're back in outbreak mode. So it does talk about suspending all visitation until one round of testing is completed. It also talks about if no additional positive cases, then visitation can resume. Again, this information, it is very dependent upon your facility and how you're set up. Do you have a unit that is just dedicated to, you know, quarantine residents or positive residents? So if you want to look at this as you get to that point, or at least try to establish it prior to, it may give you a running start on how you can deal with visitation during an outbreak. CMS also expressed to us that it also is dependent upon, you know, what's going on in the community, obviously. What's your community positivity rate or county positivity rate, and the community itself is how rampant is it in the community. So all those things have to be weighed in, and it's hard to give just a standard answer to say, hey, this is how you take care of it. It just has to be reviewed and has to be considered by, you know, all the folks that should be involved, such as your county health department and the state epidemiology folks as well. We can weigh in as well. And then it also addresses compassionate care visits, and they should be allowed at all times, regardless of vaccination status again. So going back to what compassionate care, they do define that, CMS does. And it's pretty specific to, or it isn't specific. They initially said it was all end of life type things, and then they came back and redefined it again. And so that's covered in here too in 2039. What is a compassionate care case, and when should a visit be allowed, or visitations being allowed? And we'll cover that as we go through this as well. So then visitor testing and vaccination, it's not required for testing or vaccination. It's encouraged to offer testing to visitors in medium or high positive. Again, it's encouraged, but you can't demand it, you know, of the visitors themselves. It's much like with the residents or the staff. they have a right, the residents have a right to refuse the testing or the vaccination. So keep that in mind as you go through. And it's addressed in here. And hopefully most folks will see the value of the vaccination process in protecting their loved ones as well. Compassionate care visits, again, it breaks it down a little bit more, or they added some things. They should be allowed at all times regardless of vaccination, again, regardless of the county positivity rate or an outbreak. Again, they're saying that this should be allowed. This is something we will look at based on, as a survey agency, if we get a complaint on, hey, they wouldn't allow me into the facility to review or to come in and visit my loved one who is on hospice or is in their appears to be progressing in their life to a point where they're going to be deceased. So it's a tough one. Again, it's not always easy. I know for you, it's not easy for us as well, but to try to determine when we hit that point, when a person's going to pass and when they're not. The second one is vaccinated residents can choose to have close contact, and it describes what they must do to do that. If they want to have close contact, it can be allowed. They still have to wear a mask, and that's provided in there, and we'll address that as we go through this too. Well, and it says it right below it, but must wear a well-fitted mask and perform hand hygiene before and after. Visitors should physically distance from other residents and staff. So if they're there to visit, their loved one, their mom, their dad, grandpa, grandma, whatever, they still need to distance themselves from others, including the staff. So those are the things that really some of the changes that I've seen in here that are of interest. I think there's one more here though. Let me go to the next one here. Next slide. Uh-oh, I'm locked. There we go. Okay. So then the last points I wanted to make on this revised QSO 2039 is for the surveyors, the survey considerations that we must deal with, and you should be aware of as well and hold us to them. The federal and state surveyors are not required to be vaccinated. Again, I can tell you, we offered that as part of it for our own folks. And as you know, we can't discuss who is vaccinated, who's not, but they're not required to, and federal ones as well. Excuse me. They are to be screened just like any other visitor or staff member upon entry. So any of us, whether it's federal or state surveyors, they should be screened as well, just like any other visitor. And then we must follow the core principles of COVID-19 infection prevention. And what I'm referring to again is those core elements that are cited here specifically in 2039 on page 2, the core principles, excuse me. Screening, so we need to go through the screening. We need to follow the hand hygiene requirements. We need to wear face masks, our face coverings or masks, and do the social distancing, and then appropriate use of PPE. So whatever your requirements are, we're going to follow whatever your requirements are while we're in the facility as far as PPE. So if you have any questions on that about any of the staff or any of us doing that, let me know. I'd be curious to walk through that and make sure that we're doing the right thing. So going on then, we were going to start with critical access hospital questions that we had come in. And so I'm going to let Tyler Smith, who is our non-long-term care supervisor here, take over. And I know Erica is going to weigh in at times too with these and add her side of things, which will be great. You'll hear it from both of us. And then Tyler, I'll just, if you want to let me know when to flip the slide, I will do that.
So before we start, we just had a quick question. What are the requirements for eye protection for visitors? From the public health side of things, CDC does not have a requirement for eye protection for visitors. Eye protection should be worn to protect the wearer. They should be worn when you are taking care of a suspect or confirmed patient, an individual who is in quarantine or isolation during an active outbreak, according to the transmission occurring in your facility or according to your policy. Survey, did you guys want to add anything onto that?
You know, from our standpoint, no. I think, yeah, we would agree with what you're stating.
Perfect. And then the other question is, do surveyors bring their own PPE?
Good question. Yes, we do. We've got N95s, we have gowns, we have everything. So we're trying not to burden you with wearing your equipment, so or your PPE for your staff and others. So yes, we do have it.
Thanks, Todd. All right, I will pass it back to Tyler.
Thanks, and hello, everybody. So we'll start out with question or comment number one was visitation in hospitals and critical access hospitals. And so we put it in the form of a question here, and there is a difference between all the guidance that has been sent out for long-term cares and visitation versus those for hospitals and critical access hospitals. So current CMS guidance can be found on that first link that's included in the slide. It was issued clear back in June of 2020. And part of that, I think it's about a 3-page document, and it talks about because hospital patients are vulnerable to potential COVID infections, CMS does not recommend completely reopening facilities to visitors until phase 3. In collaboration with state and local public health authorities, hospitals should develop plans for visitors that both consider patients and public health safety, as well as the emotional and care needs of patients and their families who are facing illness or life events in separation. As facilities enter phase 2, facilities may consider additional flexibilities so that patients and their families can visit. As organizations begin to expand their non-emergent COVID-19 care in phase 1 and 2, they can also consider discretionary exceptions to their visitation policies. Some exceptions may be desired under limited circumstances for visitation to facilitate patient support. And there's as I said, it's 3 pages, so there's a bit of additional information in that. The next link is CDC guidance. And so I'll let Erica, if she has comments specific to the CDC information. And then finally, that last one is the section from the QSO memo for focused infection control surveys. And it's a prompt for surveyors. And what it says is, our visitors, if permitted on based on state or federal guidance, such as reopening recommendation, instructed to frequently perform hand hygiene, limit their interactions with others in the facility, and restrict their visit to the room of the patient they are visiting or other location designated by the facility. And I didn't know, Erica, if you had something you wanted to comment on.
Yeah, I always have my 2 cents off.
Zoom.
Please make sure you guys are muting yourself. We are getting some feedback. Regarding visitation, the CDC did update their visitation guidance, and they actually did align most of it with CMS. So it's really nice to see that those 2 things do align. So just wanted to make you guys aware of that. So go ahead, Taylor.
Okay, Todd, we can go to question number 2. So this one was a 3-part question. The first one was TAG 802 and rural health networks, and this references a state rural healthcare plan and qualified entities in it identified within it. Where is this located and how do we see it? So Leslie Howe would be the one that has the information, and I put the website there for the state rural health plan. The second question or part to that question was, what are the other qualified entities? And those should be found in that rural health plan. I have heard that I think it's being updated, but I don't know when that will occur. And then the third question was, do our contracts have to identify the acute care hospital as rural health network members, or is it less formal? So the regulation states that members of the organization have entered into agreements. So those agreements would need to be entered into with individuals that are members, and facilities are going to have to be able to provide evidence as such for that to meet that requirement. So that's question number 2. Todd, if you'll go to question number 3. So some of this information is from Erica, so I'll let her comment on that. But for a number of these questions on how much longer our screening of every employee, visitor, client, person that enters our healthcare building, we're not able to estimate timeframes on when CDC or CMS is going to give updated guidance. And as we can see, we're approaching a year for updated guidance on some of this for non-long-term care. And until such time, then current guidelines are going to remain in effect until they publish updated guidance. So that's the comment from the State Survey Agency. Erica, did you have comments for this one?
Yeah, so the guidance that's referenced here is the general infection control guidance for all healthcare settings. So any healthcare setting should be referring to this guidance. For long-term care facilities, you do have a separate set of guidance from CDC that you'll want to take a look at as well. But CDC at this time states that you should screen and triage everyone entering a healthcare facility for signs and symptoms of COVID-19. As Tyler said, if this changes and our guidance changes, we'll definitely let you know. But from public health, CDC is our gold standard and what we will be referring to when we get these types of questions. Thanks, Tyler.
Thanks, Erica. So question number 4 is similar. How much longer do we restrict access to certain doors to our building? Erica put the CDC guidance on there. And again, until we receive updated guidance, this is going to continue to be what we would have to look at. I think question number 5, Todd. Okay, this is the one that Erica had a bit of information. This question was, when will we need to mask up with possible flu COVID cases instead of being masked all the time? So from our standpoint, it's going to be the same question or response as we can estimate the time frames. But Erica did put this information, so I'll let her speak if she has comments to it.
Yeah, so one thing that I would definitely recommend is, as CDC says, is create a plan for residents who leave the facility. So you're definitely going to want to have that internal discussion with members of your facility regarding what are you going to do with residents that decide to leave the facility. What risks are you going to be concerned about? It's very different when you have a resident who's going to a medical appointment, they wear their PPE, they understand social distancing, versus an individual who leaves for a couple of days, they go to a family wedding or a family reunion with over 100 people. So you're definitely going to walk through that with members of your facility to come up with a plan for residents who leave. Thanks, Tyler.
All right, thanks. Question number 6, when can our residents do outings such as fishing, eating out at a restaurant when we have no cases in our county? So for a CAW, this is really up to facility policy. Nursing homes have other guidance, but the critical access hospitals, it's really part of the facility policy. And we're going to see with a question a little bit later, it comes down to the facility's surveillance plan based on the facility assessment for identifying, tracking, and monitoring diseases. So that's where it is for the CAW. And I don't know who wants to speak for the nursing home answer.
I can. On that, for nursing homes, just remember to follow we would follow CMS guidance in that place from public health. Anyone from survey want to speak up?
Yeah, I would agree with that. And it, just depends on what the status is of the resident when they're leaving and how long they're going to be gone, all of that.
Okay, and I'll just make a quick comment here. Residents tends to be used interchangeably between residents of nursing home and perhaps swing bed patients of a CAW. However, there is a distinction between those and the regulatory sets are different. So sometimes the term residence is used interchangeably, but it does have a different meaning for the critical access hospitals. So I think we can go to question 7, Todd. When can our visitors not have to be masked if our residents are vaccinated? So that's still going to be part of source control from CDC recommendations, and they're going to continue to be enforced until we receive updated guidance. Question number 8. What PPE is required for COVID positive patients that are not having an AGP done? When can healthcare workers that have been vaccinated stop having to wear masks? So Erica put some of this information in, and from certification is going to continue to be CDC and CMS guidance until it's updated. And I don't know, Erica, if you have comments specific to this one.
In general, CDC is still recommending source control for everyone. So that's going to be, they did change their wording to say a well-fitting mask. So remember, source control is just all the time, and then you will have to possibly, put it like an N95 on or something like that for the care of certain individuals, or if you're doing an AGP or something like that. CDC has not come out with anything that says vaccinated individuals can stop wearing masks if they are healthcare workers in the healthcare setting. So in the healthcare setting is a little bit different than general population guidance. I've had some facilities that have cited the general population guidance, but remember, healthcare facilities should be referring to the healthcare facility guidance.
Yes, good point. So question number 9, Todd. When will residents who have had both COVID vaccinations and are post 2 weeks no longer require surveillance testing? So this may be getting confused with long-term care and the requirements for those, but for a critical access hospital, these 4 bullet points are what are required. You have to know how many patients in the facility currently have been diagnosed with COVID-19, either suspected or confirmed. The facility has established and implemented a surveillance plan based on facility assessments for identifying, tracking, monitoring, and/or reporting of fever, respiratory illness, and/or other signs and symptoms. The plan includes early detection, management of potentially infectious symptomatic patients, and the implementation of appropriate transmission-based precautions and PPE. And the facility has a process for communicating the diagnosis, treatment, and laboratory test results when transferring patients to acute care hospitals or other healthcare providers. So there's no set surveillance testing like there was in long-term care. So sometimes that gets confused. We'll go to question number 10. There was a question on crosswalks. I wasn't sure what someone was looking for on a crosswalk. There wasn't enough information, so I wasn't able to answer what exactly you were looking for. So if you want to email us, I can respond if there is one available. Question number 10, does the nursing staff still need to check resident temps and oxygen levels BID? So I think this first part of the question is from Erica for long-term care, or Tina or Todd.
Yeah, I can take this one because this is directly from CDC guidance. So once again, this is because the question is nursing staff need to check resident temps and oxygen levels. The guidance here, so for long-term care and nursing home, the guidance CDC specifically gave us on this for nursing homes is the following. So it does say actively monitor all residents upon admission and at least daily for fever. And remember, fever is 100.0 degrees Fahrenheit. You may see fever defined differently in other CDC guidance, but for the healthcare setting, it's 100.0. You may see 100.4 in other places for like the general population. The CDC says ideally include an assessment of oxygen saturation. So, if possible, it's recommended that you do that. If you can't do that, you may just want to know why you can't.
Also, for long-term care, this is Tina, the surveyors will look at what your facility policy is for your screening, your assessment of your residents. But as long as you're meeting that minimal requirement, then it would be okay.
And I can't remember if this had a second part to it, Todd. There it is. So then for CA, it's going to go back to previous guidance that we discussed, which having those established surveillance plan or the policy that was discussed by Tina based off of your assessment, and then identifying and tracking how you're going to accomplish those. Question number 11, so next slide. Do you ever survey clinics? So we weren't exactly sure the context of a clinic in this question, but yes, we do survey clinics, whether it's rural health clinics or whether it's clinics associated with a CCN for a hospital, can and may be reviewed during surveys. And all facilities associated with the CCN of the hospital must still meet the same COPs of the hospital regulations. So infection control would be reviewed at a hospital associated clinic under the same CCN as the main hospital would be. And there's a blurb here from Erica that the Montana HAI program offers free non-regulatory infection control assessments to healthcare settings. So if you are interested for your clinic, you can contact Ms. Erica. And question number 12, what items do you ask to see from infection prevention? So this is going to vary depending on the survey and any observations that the surveyors may be making at the time. There are 16 regulations, including the condition for critical access hospitals, which recently was updated recently within the last couple of years, but we're still waiting on guidance and the interpretation and the survey procedures for that. So currently, all of those are pending probably until the end of the PHE, and they start redoing some of the SOMs. But there are 16 different regulations that talk about education, training, surveillance, prevention, control of HAIs, the scope and complexity of services provided, governing bodies and all their responsibilities. So any of that type of information could be requested during the survey to show compliance with the COP. Question number 13, next. What happens when something is found to be immediate jeopardy? Todd, I didn't know if you wanted to talk about this.
Yeah, Tyler, I guess I was just going to talk in general about immediate jeopardy. There is a regulation that's, I think, around 22 pages that discusses what that means to the survey process and what immediate jeopardy is. It does, they have recently rewritten the immediate jeopardy requirements. I want to say in 2019 or something was their last revision, but they have us focused on areas of these three areas: the non-compliance, serious adverse outcome, and then need for immediate action. So they're trying to get us to focus more on, is there something imminent that's going to happen to a resident, to a patient in a facility, to a client. They're refocusing us on it, and I think it is better in the sense of our clarity of understanding it. It is going to take us a while, though, to get back into it. I mean, as far as immediate jeopardy, we also, I think there's another slide I put. Yeah, there is a template that we complete by the surveyor. It will be provided when announced, indicating where the immediacy is. For example, abuse. Facility must begin removal of the immediacy as soon as possible. And the one thing I can't emphasize enough is that you want to, regardless of your, whether you believe it's immediate or not, you want to try to remove that immediacy as quickly as you can. We do try to stay on site and do it. We don't, and you'll see it down here at the very bottom, surveyors do not have to remain on site. It's not a requirement of CMS, but it's to your benefit if you remove it quicker than later, because CMS will count the days, as non-compliance, and then it can add up as far as fines and penalties. So you want to make sure, again, you don't, not telling you how to do it, but just telling you what we've seen as far as other states even, is that you want to get through it and develop a removal plan. And the removal plan is not really, it's not a plan of correction. It is a plan to remove that immediacy. It's a focus plan to show what you're going to do. It's going to include training. It's going to include incorporation of the quality assurance components, but it's going to make sure that you're getting everything. Number one, the person or the potential persons protected. Number two, you're going to want to reorganize your processes, whether that be policies and procedures, and revamp them, train your staff, and then make sure there's some kind of quality assurance as you get through that process. There's a lot of different ways this can go as far as immediate jeopardy. One thing I brought up here is that if, say, we did call immediate jeopardy in your facility and then we fail to get a plan to remove, even if we're offsite, CMS will start a 23-day termination with your CMS agreement unless that is removed within that time frame. So again, immediately addressing is the most important for you as a provider. And if obviously you have a right to challenge that too further down the road if you don't believe it's appropriate. So, but I would encourage you to do that. There is a lot of different avenues this can go as far as the process, but you will be announced. It will be announced while we're on site. We don't go away and then come and say we have an immediate jeopardy at a later time. Typically, we try to make sure it's there. It's also discussed with the management team here in the office here for the State Survey Agency. So we do you know, we realize how important it is that we get this right as well, and make sure that, you know, it's appropriate to apply it. And at times, if it's a state-owned facility, we do refer to CMS for final approval, just because of the conflict of interest portion of it. But anyhow, there's a lot to this, to the immediate jeopardy presentation, and to how it works. I would encourage you to go look at that document and kind of understand it. I hope you don't ever have to go through the process, but at least be familiar with it and know where it's at if you need it. And again, I can't emphasize enough that it's really, it helps if you respond quickly and remove it, regardless of your feelings of, you know, whether it's justified or not. So anyhow, that's what I had for immediate jeopardy. Tyler, I'm going to turn it back to you.
Okay, thanks. And I would say for non-long-term care, there could be a few more processes and CMS involvement with deemed facilities and with EMTALAs and things like that. So we do have a few more procedures, and they have a bit more oversight of our process during those times. Question number 14, what sort of things have you seen with other facilities during the COVID era? Todd put these together for me. I can go over them unless you want to, Todd. So for COD, there was failure to employ an infection preventionist. There's failure to ensure a facility-wide infection prevention and control protocol with written policies and procedures for COVID. Failure to train all staff, including contracted agency and volunteer staff, on the facility's infection control policies and procedures specific to hand washing and PPE use, the storage and handling of PPE between patient use, the donning and doffing of PPE after exiting and entering patient rooms, especially with suspected or known COVID-19. Next slide. We've also had failure to implement a surveillance plan, a plan early detection and management of potentially infectious and symptomatic patients for signs and symptoms of COVID-19. Failed to actively monitor and screen all staff at the beginning of their shift for signs and symptoms of COVID-19, and failed to document the presence of such illness for all staff. The failure to implement timely interventions with the appropriate transmission-based precautions, including signage on patient door or patient rooms regarding need for transmission-based precautions for patients with suspected or confirmed signs and symptoms of COVID-19, and established a clear delineation between clean areas and potentially contaminated areas in order to mitigate the spread. Ensure all staff were educated and trained and appropriately used PPE while providing care between patients with and without COVID-19, and failed to ensure PPE used for extended or reuse was used. Reuse was used, cleaned, decontaminated, and properly stored between uses according to national guidelines for infection prevention. Establish a facility-wide IPCP, including written standards, policies, and procedures that are current and based on national standards for undiagnosed respiratory illnesses and COVID. Failed to establish and implement a system for tracking of a surveillance, prevention, and control of respiratory illness or other signs and symptoms of COVID-19 for both patients and staff in order to prevent the spread of COVID-19, and failed to demonstrate the success or sustainability of such activities. Question, so there was another question. There was another couple
Tyler,
questions.
this is the other part of it for long-term care. These are the citations that we've been citing for COVID, any of the facility or the focused infection control surveys. So I won't read through them all, but they're listed here. And I don't know, Tina, do you have others that this was a list you generated some time ago, but I don't know if there's anything you want to add to these.
No, I did review it and it looks like they're all really still appropriate. We just have one occasionally that occurs now and then, but they're all still the same areas.
Okay, thank you. And Tyler, I'm sorry, you want to go back to the,
Nope, sorry, I forgot that slide was in there. I think it's after this.
okay, gotcha. So this was on the question, Tyler, I'll let you take this one.
Okay, nurse sitting at desk with no patients in hospital, no other staff in sight, can we remove masks? So this continues the implementation of universal source control. Some of this information is from Erica, but the guidance is still that healthcare professionals still wear masks at all times. And Erica, did you have a comment on that?
Nope, I think you covered it.
Okay, I think there were two more submitted last minute that we didn't get put into the presentation. One was, do outpatients coming for labs or x-ray outpatient services need screening for COVID at entrances with temperature screenings? So we already discussed that in a few. The current guidance continues to be source control and monitoring everyone that comes into the building. And then the last question we received, will CMS let states address COVID issues based on local activity, vaccination status of employees and residents, or will everything continue to remain the same for the US as a whole? And so for that one, really we can't anticipate what CMS or CDC is going to give us for future guidance. So until we receive it, the current guidance is going to remain in effect. And that, I think, ends for CAW questions for me.
That's right. Thanks, Tyler.
Thank you.
Thank you, Tyler. All
And so-
righty. Oh, go ahead, Todd.
Actually, we have this one IP question I had to put in here that I think is specific to Erica.
Okay.
Yeah, so kind of going back to what we discussed earlier. So this is the CDC guidance on that. So please do continue to follow the CDC guidance regarding how often you should be evaluating residents, and CDC does say at least daily. Do please try to get that assessment of oxygen saturation. So that's, once again, they say ideally including assessment. So just some more guidance for you guys. There's specific long-term care infection prevention guidance, and then there's also that general infection control guidance. So that's all I had to say.
All right, thanks, Erica. So Tina, you're ready here now with the first long-term care one.
Okay, thank you. So the first question was, when visitation occurs outside and 6 feet apart, no touching, and do the residents still need to wear masks? And also family. Yes is the response for that. That if residents, if tolerated, should wear a well-fitting mask when they're in the facility or protection. And then they can remove their mask if they're in their room and then return it back on if they have someone come into the room, whether it be staff, other residents, family, anything like that. And then facilities would want to educate the residents and the families through educational resources on information related to how they can protect themselves. Down at the bottom, we do have a link that is addressing physical distancing and hand hygiene, which is on the CDC website. And the next slide, Todd. Question number 2 is, the new CDC guidance states that facilities located in areas with minimal to no community transmission might elect to use a risk-based approach to determining which residents require quarantine upon admission or readmission. The decision should be based on whether the resident had close contact with someone with COVID infection while outside the facility, and there was consistent adherence to IPC practices in the healthcare setting during transport or in the community. Question was, is Montana going to adopt this risk assessment strategy? And the response to that is, it is up to the provider to determine what type of strategy they're going to use. The state survey agencies would look at that to ensure that it's meeting their requirements, but the facility does have the choice to choose which option they're going to follow. And they would want to weigh the pros and cons of those options. And that is something that we talked about today during a call that we had with Erica. And there obviously are some risks with using the risk-based process. Erica, if you wanted to note anything on that you wanted to add.
Yeah, I think, from the local or from public health perspective, we use CDC as our gold standard. So once again, you're going to want to discuss internally what kind of approach you're going to take. What is your facility policy going to say? What type of risks are you concerned about? Once again, I think there's a big difference between an individual who's wearing a surgical mask going to a medical appointment back to the facility versus a resident who may be going to a wedding or a birthday party or some large gathering where the potential of acquiring COVID-19 is higher, right? That risk is higher.
Thank you, Erica. And next question, Todd. Question number 3 addresses whether or not the door should be closed for a resident on a memory care unit or a secured unit if there's COVID concerns. And CMS did put out considerations for memory care units, as did the CDC, they're in coordination. And so we have added the links here for anyone who would like to go in and address those or read them. But it shows that when residents are on a memory care unit and suspected to have or confirmed COVID, specific things that they could do to look at. Obviously, you would want to look at the safety of the resident, and if the door is going to be closed, you would want to look at the ventilation and have maintenance involved with all of that. But we do have also a link for the designated COVID-19 care unit for review, and then additional testing that may be needed. So CMS and the CDC has worked together to put out the information in case there was a situation on a memory care unit specifically. And the next slide, Todd. Question number 4 addresses whether or not a resident, if they're unable to wear a mask and there's going to be a compassionate care visit, is the visitor considered to be in close contact, and is it if they wear PPE? And the answer to that is yes, they would be in close contact. CDC has defined what close contact is. We have provided the information here so you can review that. And then someone who has been within 6 feet of an infected person, laboratory confirmed or clinically compatible illness for a cumulative total of 15 minutes or more over a 24-hour period. And so it explains the definition of what CDC identifies as close contact. So if you have a compassionate care visit occurring, you would want to take a look at that situation just to make sure that protective measures are in place for not only that resident, but also for the facility itself. Also, you would want to look at determining the length of the visit to see whether or not that length of time is going to be a factor regarding the risk. And question number 4. Will there be penalties for nursing home if the staff vaccination rate is lower, and what % would that be? The state survey agency does not have any involvement specifically with identifying or setting any form of penalties. And so that would be something that we unfortunately cannot provide a response to, but we do know that they have allowed residents and staff to refuse the vaccination. So they would be taking that into account if there were penalties that were going to be imposed related to the vaccination of staff or residents.
Hey, Tina, this is Todd. Just to add some clarity to that too, I did ask CMS specifically this question, and they did direct me to the fact that they do allow residents to refuse the vaccinations, and as we all know, the staff can do as well. It's up to you as a provider to determine how you're going to do that. I know some of you have tried some different ways to increase that vaccination rate for your staff, but anyhow, at this time they don't see anywhere where they're going to, penalize a facility for those lower rates.
All righty, question number 6. If a visitor is fully vaccinated, is there any allowance of physical contact? So that's the first question. We have several questions on here. And really, again, as we just discussed, the facility is going to want to weigh the consequences and the risk factors involved. Regardless of the vaccination status, there should always be protective measures in place. You would want to be looking at the time of the visit, the compassionate care situation, what's in the best interest of the resident, but there should always be some form of precautionary measures in place for the risk of infection transfer. If a visitor shows proof of being fully vaccinated, do they still need to be rapid tested? So Erica, would you like to address the testing portion of these questions?
Yeah, I sure can. So CDC really has not updated their guidance related to vaccination and testing, right? So if a visitor shows proof of being fully vaccinated, do they still need to be rapid tested? Well, what CMS and CDC says is, that's an offer you can make, right? So you can't force somebody to be tested. You can't force a swab up their nose, but you can offer it. There's nothing that says, vaccinated people should not be tested. We know the vaccine's not 100% effective, right? So individuals who have been fully vaccinated or that are within their vaccination series could still become cases. And so that's why these other infection control measures are so important. Do visitors still need to be rapid tested regardless? So answer to that is, kind of up to your guys' policy, and if the individual is willing to get tested. Is there specific guidelines as far as residents who are vaccinated and unvaccinated? So once again, for surveillance purposes, you do not need to be testing residents, right? However, you should always test a resident if they're symptomatic, if they're a close contact to a confirmed case, during an outbreak response. So there's certain scenarios where you'd want to test residents. And then do staff members still need to be PCR tested on a weekly basis if they're fully vaccinated? So once again, CDC and CMS has not updated testing guidance based upon your vaccination status. So if a staff member is fully vaccinated, they should still be included in that testing. The surveillance testing, and remember your surveillance testing, the frequency of that is based upon your county positivity rate. If you're in outbreak status, we would still want to test all previously negative individuals not within their 90 days of an active infection. So hopefully that answers those questions.
Thank you, Erica. All right, question number 7. CDC states that in most circumstances, residents who leave the facility with family for 24 hours would not have to be quarantined upon return. That would depend on the situation going on with the resident when they're at a facility. So source control measures and distancing measures should be in place, and the facility is going to want to make sure that they're talking to that resident and assessing the resident to determine whether or not that resident has come into contact with anybody who was potentially COVID, like in contact with anybody who had COVID or anybody that was COVID positive, and they would want to make sure that they have some type of monitoring in place after that resident comes in. But it just depends on the situation really when that resident is out of the facility. So we do have links for source control measures on the page here, which is for the cloth mask, the face mask, and the respirators. And Todd, if you can go to the next page, we continue on, and it shows the following activities can be considered for residents who do not have current suspected or confirmed SARS, including those who have fully recovered and residents who have not had close contact. So that could be a resident who's returning back to the facility. So CMS and the CDC does show information of what residents are able to do in the situation where they have not come into contact with someone. We also have links here for the close contact, and again, what that definition is. We have interim public health recommendations for fully vaccinated people, and then we also have the quarantine considerations for residents who leave the facility in the CDC guidelines, and that is under to create a plan for residents who leave the facility on the CDC website. And question number 8, Todd. I just reread the QSO and saw that it says these scenarios include limiting indoor visitation for, and there are several questions there. And down towards the bottom it says, my question is the above scenario only relevant for the non-vaccinated residents in the facility or for all vaccinated and unvaccinated residents? And the next page, Todd. So the facility would want to implement, excuse me, let me go back here. So the question becomes relevant is the facilities admit more residents from hospitals that are not yet fully vaccinated. So the CDC and CMS has worked together and they have come up with the language, and they specifically use the word "and," which is here, in the language of the update. And it has to be both issues for why a facility is not going to do this. So if you look here, you have updated healthcare infection prevention and control recommendations. Indoor visitation could be permitted for all residents except as noted below. And then it gives you all of those exceptions here. So the facilities would want to review those and determine how that situation is applicable to the situation currently going on at the facility. For vaccinated and unvaccinated residents with SARS infection, until they have met criteria to discontinue transmission-based precautions, CDC has outlined that on their website, and CMS is following the CDC guidance on that. So we do recommend that you take a look at that language on the CDC website. And then another one of the criteria is vaccinated and unvaccinated residents in quarantine until they have met criteria for release from quarantine. So for indoor visitation, this should be limited solely to compassionate care situations only for that specific criteria shown on that slide. Facilities that are in an outbreak status should follow the guidance from state and local health authorities, and it should show when the visitation should be paused. If at any time a facility has a staff member or a resident who is positive for COVID, definitely they start the outbreak status. Alrighty, and question number 9. Does the survey team take into consideration that the facilities have struggled to keep residents alive, let alone follow all the CMS regulations, citing facilities for deficient care of non-life-threatening situations such as a care plan? It is felt that this is perhaps a kick in the teeth for the facilities. Our staff members have been through so much. The Certification Bureau and the surveyors do understand, and we empathize that the facilities have been through a lot, as have the residents in the last year. There have been many losses throughout the state and the nation, and some of the individuals within the Bureau ourselves have had some of those losses experienced within their family. So we do take that into consideration, and Todd had mentioned previously that we had talked about outcomes, and I had talked about outcomes with CMS at the beginning of this last week, and then also during the week with a couple of the regional office individuals. And we look at those outcomes, and we have met with the surveyors. We did that today, and we talked about that more in length and trying to focus on those, because we do understand the facilities are still having struggles. The focus has been on COVID and the prevention of COVID, but yet still maintaining those things that they need to maintain. And so as we move forward, we will continue to do that. But in the end, CMS still does have expectations of the surveyors and the state survey agency. And so we will have to weigh those. if something comes up, but we can assure you that that is definitely something that we look at and that we consider throughout the survey process. Todd, did you have anything you wanted to add to that?
No, I think, again, I guess like Tina had indicated, we're aware of the struggles out there that all of you are going through or have been challenged with, and we're thinking of that as well. And we'll continue to remind our staff of that and keep it in the forefronts of our minds, so we just focus on those outcomes, and that's where we'll be headed. Towards looking at outcomes for residents. And so thank you for the comment. We appreciate it, and it helps us focus ourselves too.
All right, question number 10. We have a resident who only wants vaccinated staff to work with them. Is this something that we have to accommodate? CMS does not require that vaccinations are mandatory for the staff or the residents, and so the facility would not be required to do this. The one thing you do want to take into consideration is, for example, if you have a resident who has a preference that they do not want male caregivers or female caregivers because of specific purposes, let's say that person was traumatized at some point in their past life, you would want to take that into consideration and do what you could, hopefully, to assist that resident with not having any negative feelings or outcomes from care by that person. Now, obviously, if you have staff who are choosing to not be vaccinated, you would want to go in and you would want to look at the process that staff member is using. You would want to make sure the facility is upholding the infection control processes for prevention of the spread of COVID, and then possibly even provide some education to the resident on those protective measures that the facility is taking. But there is nowhere that specifically shows, or CMS has said, that a facility would not have to allow a resident to choose who is going to provide the care for them. As long as the facility can provide the services necessary with the qualified staff necessary, the facility would have to determine how they would go about doing that if that situation did arise. And Todd, next question. We have 2 cases of COVID reinfection, and reinfection is not as rare as we first thought. Is this happening across the state? The Certification Bureau does not specifically look at or track anything that has to do with reinfection of COVID. Erica, if there is something that you would like to add on that, but we do not have any involvement in it at all.
Yeah, so we actually do track that in infection or in epidemiology. So you might hear from me if I am investigating a case of reinfection, looking into it a little bit more. So just really quickly, reinfection and breakthrough are 2 different things. So reinfection, the definition of that is an individual who has had COVID and then gets COVID again. The definition of vaccine breakthrough are individuals who are fully vaccinated. So once again, fully vaccinated means that you are post 2 weeks of your complete COVID-19 series. So it's not that you just have one vaccine, it's and you're 1 day out. It's either 2 weeks post Johnson & Johnson or 2 weeks post your second dose of Moderna or Pfizer. So there is a difference. We are publishing a EPI report on our number of breakthrough cases. That should be coming out soon. I did put that in the chat. There is a link to it. There's actually a lot of data that we publish on our webpage, and I'll put it in the chat again, but definitely check that out. We even have a long-term care ALF outbreak table, so you know where our numbers are at, but we are tracking all of that here.
Thank you, Erica. All right, and next question. Question number 10, the 14-day quarantine observation for new admissions or readmission resident that is fully vaccinated, CDC states that it is not required. What is Montana's interpretation? This was discussed with CMS, and CMS states that they are working with CDC and they have no problems with the way that CDC worded that in their information on their website. So it shows on there that the quarantine would not be required for the new admissions, but you want to make sure that you look to make sure that you know what's going on with the resident, that the resident, if they've been fully vaccinated, plus 14 days past the vaccination completion, 24 hours or less if they were off-site, that there's been no exposure to COVID-19, then there would be no need for quarantine. So CDC or the CMS does agree with that one line item, that's that last little section of content on the CDC website for that topic specifically. And question 11, what is the most current crosswalk infection prevention for state agencies? And Todd has provided the link here for those. And we currently have for long-term care, F880 infection control prevention, which used to be F441. We have F881 antibiotic stewardship, which is new as of November of 2017. F882, infection preventionist qualifications, which is also new as of November 2017. 883, influenza and pneumococcal immunizations, which used to be F334. F884 reporting, National Health Safety Network. That's actually fairly new for both the provider and us. F885 reporting residents, representatives, and families. That is also new for providers and us, and it's came about because of COVID. And then F886 COVID-19 testing, residents and staff, and that also is new for both provider and the state survey agency. The long-term care survey pathways dated 12/10 of 2020 do have all of the combined investigation information for infection control, which cover all of those areas also. And those can be located on the CMS website. And I do not believe there's any other questions. Nope. So there was a lot of people on their call. I recognize the names I haven't seen for a long time or got to meet with at the meetings for Montana Healthcare, anything like that. So I just want to say hi. I hope everybody's doing really well. Yeah, it's been a long year. I hope everybody's hanging in there.
Thank you, Tina, and thank you, Todd and Tyler. We do have quite a few questions in the chat box, so we will try to get through what we can. So I think I'll kind of start on the bottom and go up because I've been answering questions as we've been going. So the first one is, what if we have an admission with only one vaccination? So Elsie, what CDC says is that new admissions do not need to be placed on 14-day quarantine if they are fully vaccinated. So that is 2 weeks post either their second dose of Pfizer or Moderna, or 2 weeks post their Johnson & Johnson. If they're not fully vaccinated, they should be placed on that 14-day quarantine. The other caveat to that is that they should not have contact, right, with a confirmed COVID-19 case. You want to make sure they're not a close contact, or else they should be on quarantine, and you'll want to make sure that they are fully vaccinated. So hopefully that answers your question. We have a question about quarantine. So we were told by survey agency that CMS requires 14 days before an employee can return to work after a positive COVID test. Is that the position of the survey agency?
That would depend on the situation going on to the facility and the staff member and the timeline of what was going on, because the information has changed from last year to this year. So that one's kind of a hard one to respond to directly. So we would need more information related to the situation at hand.
Perfect. Yeah, and you know, there is a difference between quarantine and isolation. It's really important that you're working with your local public health departments when determining when an individual can be released from isolation. Remember, isolation means infected, so isolation applies to infected individuals. Quarantine is close contacts. So just, you know, I know those terms are often interchangeable, but they really mean completely different things. And we even use quarantine in a couple of different ways. So just a reminder on that. Next question is, do you consider fully vaccinated people exposed if within 6 feet of a positive individual? So that is a little complicated. It depends on who the exposed individual is, okay? So if it is a general public, if you have a fully vaccinated person who's exposed to a confirmed case, they do not need to quarantine. If you have a healthcare worker who has no underlying immunocompromising conditions, they do not need to quarantine. If you have an immunocompromised healthcare worker who is exposed, they should quarantine. If you have a resident or I believe they say patients, specific patients, then they should quarantine. So it really depends on who the exposed individual is, what their vaccine status is, if they need to quarantine or not. So that's kind of a complicated one, but hopefully that kind of helps clear that up for you, Leslie. You can find that in the updated healthcare worker guidance for vaccinated individuals. Next question is, what is the recommended time allotted for visitor and residents to be allowed to touch during the visit? I'll start by saying there's no guidance from CDC stating exactly the amount of time. State survey, is there anything from you guys?
There is not. It's actually the same. The facility would really want to look at that, make sure you have your protective measures in place, and then following that definition of the CDC of what they consider to be close contact and the risk that that poses if that's not followed.
Perfect. And once again, please work with your local public health. When you are looking at if an individual is a close contact, local public health will be able to work with you on that. So follow up, all residents will be considered exposed regardless of vaccination status. Correct. At this point in time, CDC says if a resident meets the criteria for close contact, remember that's within 6 feet for 15 minutes or more, regardless of your vaccination status, you should still be placed on 14-day quarantine. Day 0 is your last day of exposure, and then you calculate 14 days from there. All right, so I'm gonna try to move up in the chat to some earlier questions that we had gotten. So let me see if I can find them. Got that one answered. Okay, so we have a lot of questions about screening. So can, individuals self-screen? What type of screening can occur? So I put some guidance in there from CDC. CDC gives you options. One of the options is that self-screen. One thing I would say is if you're taking that approach, how are you going to monitor if somebody does check a yes on your screening form? How is that checked to make sure that that individual then is placed in, the appropriate room, wearing the appropriate PPE, that the appropriate response is given for those results? Because, if they just check yes, but then walk into the appointment, how are you guys going to deal with that? Survey, do you guys have any comments on the screening process within either the CAW or the long-term care facility? Any thoughts about that?
That has been a concern if the staff are self-screening because of the accountability and how the facility will hold them accountable. We have had a few situations where the staff have marked on their documentation that they did have symptoms, and it wasn't caught until several days later when the facility was actually looking at that documentation. So it's something that the facility should really have a tight grip on. And the CMS, they're not saying that you can't do it, but they do say that if you're going to do it, you really need to be on top of it because it does allow for a lot of risk factors to be involved.
Thanks, Tina. Our next question is, oh, sorry, Todd, did you want to go?
This is Tyler. I was just going to say screening was addressed in the updated QSO memo for non-long-term care at 21-08, and there's a section clarifying guidance for screening of individuals entering the healthcare facility. So that should address some of the questions.
Perfect. Thank you, Tyler. Next question is wondering if there is guidance on allowing visitors for end-of-life care on COVID positive patient in a critical access hospital.
Okay, this is Tyler. So that's going to come down to the facility policy on what you've done for the assessment of your risks and review CDC guidance on interactions with those. But there are cases for visitation at end of life care that they have allowed for. So that's going to take all of that into consideration.
Thank
I
you,
don't know if
Tyler.
you have something from the public health perspective, Erica, but
You know, I don't. So, you know, I think once again, you're going to want to look at what your policy states. If you are allowing, you know, individuals to come in, work with your local public health once again, because that could be an individual that's going to be identified as a close contact. So you're going to have to do, you know, some quarantine or follow up. So, you know, just once again, please work with your local public health. We have a question. Can staff wear cloth masks or does it need to be surgical N95 masks? Some staff have allergic reactions. So we do not consider cloth-based coverings as PPE. So if you have staff wearing those, that does not serve as PPE. And so they could be considered exposed if they are exposed to a confirmed case. We really wouldn't recommend using a cloth mask on a healthcare worker. I've included the definition of healthcare personnel in this chat as well. You'll want to check out those definitions because the definition of healthcare personnel is pretty broad in our healthcare settings. I did see some recommendations for other types of masks. So if you guys could just keep sharing, you know, your recommendations, what you've learned, lessons learned regarding these types of questions, I know that's always really appreciated. So if you have a resource for Casey, that would be awesome. You know, some more questions about screening. So I think we've covered that. One request was, could surveyors start bringing reams of paper to surveys due to the request for printing so many things? So just a consideration for you guys.
Could you repeat the beginning of that? I'm sorry, Erica.
Oh, no, you're fine. We just got asked if State Survey could start bringing reams of paper to the surveys to assist with the printing requests.
Yeah, we will talk to them about that. We do request that it is as much of a paperless process as we can get. And if the surveyors have records available electronically that they can access, they should be able to access those records in that manner. And the documentation that they're returning to the office should only really be the necessary documentation that they need for the deficiencies to either show evidence that a situation is not supported or substantiated, or evidence that it is supported or substantiated. And then there are certain documents that, of course, we would need, such as policies, procedures, and things like that. So we do look to see if we can have as much of a paperless process as possible, and we will provide reminders for that to the surveyors. And I'll talk to Todd and Tyler and Tony about the ream of paper.
Thank you, Tina. We have another question. When a resident is unable to tolerate wearing a mask, should they still be allowed in-house visitors? If not, any ideas how to mitigate this risk and still allow the resident to see their loved ones? I think from the public health perspective, you know, if they can't, we understand not every resident can wear a mask, so that's why it's important those other infection control measures are being put in place, such as social distancing and screening. You'll want to make sure, you know, that the risk is minimized as much as you can. Surveyors?
Yeah, agreed, Erica.
Perfect. So we have one more question, and then I think we'll call it a day. I will go through the chat and make sure we've covered everything. But feel free to shoot me an email, and you know, or Todd an email or Tina, and we'll get you your answer back. The last question we'll answer for today is, we have been instructed by local and state health departments that employees that test positive for COVID and are asymptomatic or have mild symptoms require isolation for 10 days from the first symptoms or positive test for asymptomatic. We were told that this does not match CMS guidelines, which require 14 days. There is a conflict. I don't think the isolation guidelines changed from when they were first issued. Can you clarify? So that might be another one where you need more information, kind of case by case basis.
Yeah, and if we could get that like sent to us, we can take a look at that a little bit more too. Todd, if you're in agreement, and Tyler.
Yes, that sounds good.
Perfect. Well, thank you. It looks like we still have 81 people on, so thank you for your time. Thank you for staying on. I know this was an extended webinar from our usual time, but we really wanted to get those questions answered for you. Thank you to all that submitted questions for today's webinar. As always, please continue to let us know if you have any topics for webinars next week. So March 15th is actually going to be our APIC Montana update. And we have a really awesome speaker. We have Dr. Koo from Billings Clinic, who is planning on speaking related to vaccination. So that's going to be an awesome webinar. I'm really looking forward to that. On March 23rd, we have our own Liz Adams, who will be presenting on interfacility communication, something we've really seen throughout this COVID pandemic. And then on March 31st, an APIC review, disentangling disinfectants, and we actually have one of our own individuals here in the state of Montana working at one of our critical access hospitals who will be presenting on that. So once again, thank you. We have this infection prevention webinar every Thursday from 2 to 3. Feel free to join us anytime. All right, thanks all. Bye.